Hot flashes and night sweats, fatigue, anxiety, sleep issues, mood swings, muscle and joint issues, skin issues, digestive issues. Every woman's hormones fall at menopause. But if this hormone decline is what caused those symptoms, then every woman should have those symptoms, and they don't. Some women sail through perimenopause and menopause with barely a symptom at all, while others can have debilitating symptoms for months, if not years. And sometimes these symptoms can persist into their 60s and 70s. They never come out of the menopausal symptom picture. The same hormone decline in every woman, but completely different outcomes. No one is asking the question, why is that the case, and no one's explaining the answer. What if menopause didn't create the problem? What if it revealed something that was already there? Something your hormones have been managing and suppressing for years during the hormonal years of your life. Your hormones weren't just doing one job. They weren't just reproductive hormones. Estrogen, progesterone, and testosterone are also anti-inflammatory hormones. And when these hormones decline at menopause, they stop doing both of those jobs, including the anti-inflammatory job. And inflammation could come to the surface at that point. So stay with me for this video, because once you see this, your menopausal symptoms and possibly your entire health history could start to read like the same book. So let's talk about menopause and inflammation. We're going to talk about 3 common scenarios we see in clinic with regards to menopausal symptoms. We have woman A, 6 months of period irregularity, occasional warmth episodes. Within 6 months, the periods have stopped and she's into her postmenopausal life with very little disruption. Then we come to woman B. Her symptom picture is a little bit broader. 3 years of what we'll call functional decline. Hot flashes and night sweats, some joint pain, some skin changes and things like that. Brain fog, memory issues, sleep issues, and a little bit of minor weight gain and bloating. This would be more the average patient that we see. And then finally we have woman C. In her 60s with still no more improvements in her symptoms. Hot flashes, night sweats, fatigue, brain fog, memory, sleep issues, muscle and joint, digestive issues, skin issues, weight gain. All 3 of these women went through the exact same hormone decline. And look at the drastic differences in their symptom pictures. Another key point I want to mention here is woman C. A woman in her 60s and 70s where periods have stopped 5, 10, 15 years earlier, it's very unlikely those symptoms have anything to do with the menopausal hormone change associated with their period stopping. The standard model for explaining menopausal symptoms in women just doesn't fit the gaps that we see here in this scenario. The current menopausal paradigm or explanation: estrogen, progesterone, and testosterone, they start to fall. We have period irregularity and eventually the periods stop. And then we'd end up with what we call hormonal homeostasis issues or hormonal balance issues. This is what the current conventional paradigm for menopause would blame the symptoms on. Hot flashes, sweats, sleep, mood, bone density issues, joint issues, and so forth. Now, the reproductive hormone decline at menopause absolutely is associated with all these changes. This explanation isn't wrong. The explanation is just incomplete. It doesn't explain the differences between women who have no symptoms and women who suffer terribly through menopause. To restate it, the major gap here is that the hormones fell in both these women. So why didn't both women suffer equally through that change? Well, it's possible woman C here had a pre-existing underlying inflammatory problem that woman A didn't have. Through her hormonal reproductive years, those hormones were keeping that inflammation below the surface. And then when the hormones started to decline, the inflammation started to rise. So in this scenario, the menopause didn't cause the symptoms. The menopause allowed an underlying inflammatory to come to the surface. But because it happened at that time in a woman's life, they automatically just get attributed to menopause. There's a simple little test I'll ask some women about when they come into office. It's an anti-inflammatory medication test. We're going to talk about that next. Let's look at some of the common menopausal symptoms: muscle and joint pain, headaches, skin rashes, sinus problems, and things like that. Quite often, if a woman has a headache or a muscle pain or a joint pain, they're going to go for what's called an NSAID medication, non-steroidal anti-inflammatory drug, ibuprofen, naproxen, or aspirin. Those are anti-inflammatory medications. They can only help with a symptom if the symptom is caused by inflammation. Imagine a woman has some skin rashes and she uses a topical steroid on that skin rash. The topical steroid is an anti-inflammatory medication. It can only help with the symptom if it's caused by inflammation. These medications have zero hormonal action. They are pure, straight anti-inflammatory medications. So if these medications help with the symptom is inflammatory, not hormonal. Just sit with that for a minute and think about it. Have you ever taken any of those types of medications for those symptoms, and have you seen benefits with them? If you have, that is telltale for that symptom being an inflammatory symptom and not a hormonal symptom. We're going to revisit this anti-inflammatory test later when we talk about hormone replacement therapy. We're going to talk about inflammation symptom breakpoints. If you look at this little graph, these little lines here, these little blue lines would represent the amount of inflammation your body can suppress and keep below the surface at certain ages. At 35, it's up here. At 40, it's down to here. It drops as we get older. As our hormones fall, the inflammation levels tend to rise. So let's take woman A. Let's imagine she has a little bit of underlying inflammation right here. When she's 35, that can suppress that little volcano with no problems. Same thing at 40. Same thing at 45. From 45 to 50, that's where things may show a little bit of irregularity. Some of the symptoms may start to surface, but they're very mild because her inflammatory load is quite low. Now let's look at woman B here. She has more significant underlying inflammatory load, inflammatory issues. She goes from 35 to 40 without much issue, but once she hits 40 and the perimenopausal slide starts to speed up a little bit, she's going to start to experience some of these symptoms a little bit earlier. So her periods may be continuing, but this is where we can start to see unexplained joint pain, unexplained fatigue, bloating and digestive issues. Quite often those are attributed to the perimenopausal changes that happen at that time frame. Now let's look at woman C here. She has a really large inflammatory load. If we draw the line over here, we're going to see it kind of kicking in mid-30s to early 40s. When she goes from 35 to 40, her body's inflammatory suppression mode has already kind of reached the inflammation. So as this line continues to drop, these inflammatory symptoms are going to become more pronounced. So we have 3 women here, all of similar age, but drastically different experiences through menopause. And this underlying inflammatory load can be an explanation for why it's so different. As these hormones fall, our body's ability to fight the inflammation becomes less, and the inflammation starts to surface like this. So we have 3 women with the same hormonal decline at menopause, but drastically different levels of those inflammatory or menopausal symptoms. So we have reproductive hormones. They regulate menstrual cycles. They regulate ovulation, the start of the period. They support the uterine lining for implantation for pregnancies. The hormones assist spermatogenesis in men. These are very obvious reproductive functions of these hormones. But job 2 is immune modulation and inflammatory suppression. Most people have never really thought of those hormones as anti-inflammatory, but they are significant anti-inflammatory hormones. Both these jobs are running continuously through your life. When the hormones decline at menopause, both jobs diminish. The conventional paradigm for menopause focuses on job 1, the reproductive hormone. This video, we're going to focus on that second job, the inflammatory job. We're going to talk about 4 of the main hormones associated with hormonal decline at menopause and andropause. We'll talk about that more later on in the video. Estrogen is an anti-inflammatory hormone. Estrogen helps modulate a lot of the inflammatory responses, the cytokines, and the signaling mechanisms for what causes inflammation. It supports what's called DAO, diamine oxidase. This is an enzyme associated with histamine breakdown in the body. Histamine is a compound that causes redness, swelling, itching, and hives. That's what most people associate with histamine. Diamine oxidase, or DAO, is what can break that histamine down and relieve those histamine symptoms in people. When estrogen fails, that DAO activity lessens and the histamine response and the ability to clear histamine from the system weakens. Estrogen is critical for maintaining the gut lining as well. Imagine when we go through perimenopause and men go through andropause, we start to get wrinkles in our skin. That's the breakdown of the collagen and the connections in that skin. Estrogen is what supports that. As estrogen falls, we start to see those weakenings there. Well, shortly we're going to talk about what we call our internal skin, our mucous membranes. The same epithelial support that estrogen provides for our skin on the outside is provided for the epithelial tissue on the skin on the inside of our body as well. That's really important. All of these estrogen-based anti-inflammatory properties diminish as we go through perimenopause and andropause. Progesterone is an anti-inflammatory. Quite often, progesterone tends to fall a little bit quicker and sooner than estrogen does in women. It's a critical component of our mucous membrane, not just from the mouth of the rectum, but the urinary tract, the vaginal tract, the lungs, the sinuses, and so forth. Lowering progesterone levels can actually start to weaken that mucosal barrier. Progesterone plays a critical role in mast cell stabilization. Mast cells are little balloons in your body. They're in every tissue in your body, especially the epithelial cells. These little balloons are filled with histamine. Mast cell is what can maintain the structure of those mast cells so the histamine doesn't get released too easily. As we lose progesterone, the stability of those mast cells weakens, so they're much more reactive. They break open easier. They can release histamine easier, and histamine causes some inflammation responses. So again, these anti-inflammatory properties of progesterone decline as progesterone declines. Testosterone in men and women is an anti-inflammatory hormone. It suppresses a lot of the common cytokines, which are little signaling molecules that can be associated with inflammation. Common ones here would be tumor necrosis factor and interleukin-6. These are 2 of the cytokines associated with a lot of autoimmune conditions, a lot of skin conditions, a lot of muscle and joint conditions. A lot of the medications that people are given for those conditions actually suppress and target these cytokines and reduce them in order to see improvements in the condition. Testosterone can actually suppress the inflammatory properties of those 2 cytokines, As testosterone falls, the inflammatory actions become worse. Testosterone is also critical in what we call mitochondrial energy support. This becomes an issue when we start to have fatigue issues and brain fog issues and focus issues as we go through perimenopause and andropause. Again, anti-inflammatory properties of testosterone decline as testosterone falls during perimenopause and andropause. And finally, for this video, we're going to talk about cortisol. Most people have heard of cortisol. Cortisol is your body's primary anti-inflammatory hormone. That's why people get cortisone shots when they have an inflammatory problem in a muscle or joint. A lot of the anti-inflammatory topicals that we use for psoriasis and eczema are versions of cortisone or a synthetic form of cortisol. It's an anti-inflammatory hormone. It's also a stress hormone. It has a critical role to play from our pituitary gland into our stress responses. So it helps modulate mood and anxiety and memory and these sorts of things. It plays a critical role in glucose uptake or blood sugar control mechanisms and interactions with insulin and glucagon. In a summary way of thinking of it, it helps us adapt to physical and psychological stress. That's where most people think of cortisol as a stress hormone. Well, it's not just estrogen, progesterone, and testosterone that fall at menopause and andropause. All of our hormones tend to fall. And cortisol is one of those hormones that tends to fall as we get older as well. We aren't born with an infinite supply of these hormones for our whole life, and cortisol falls into that category as well. Cortisol also plays a major role in contributing to the chronic fatigue states that tend to happen as the hormones decline as well. We have a separate video on that, on chronic fatigue and inflammation. There'll be a link in the video description below. So cortisol is a form of adrenaline. There's several different forms of adrenaline. We won't get into all of them in this video. We have cortisol, epinephrine, norepinephrine, dopamine, aldosterone, DHEA. Estrogen, progesterone, testosterone is actually a form of steroid hormones. That's important to know. These hormones are all forms of adrenaline. Adrenaline, regardless of what form we're talking about, they're formed in the adrenal gland. A little gland, it sits like a sponge sitting on top of the kidney, and that sponge drips adrenaline into the bloodstream all day, every day to help control stress. Now, the reason we have so many types of adrenaline is there's many different types of stress that we have to have adrenaline to suppress. Most people think of stress as just psychological. So finances, spouses, friends, work, career, school, grief, and those sorts of psychological components of our lives. Adrenaline in various forms can actually help come out and put little caps on all those volcanoes. But most people don't think of stress as physiological, and this is the critical component for what we're talking about in today's video. What are physiological stresses? Well, hormones in women. Twice a month, estrogen surges and then progesterone surges. The liver, kidneys, and bowels have to clean that hormone up month after month for decades. We don't have to tell a woman how big a physical stress on her body a pregnancy and lactation is. Chronic immune issues with infections and colds and flus and bugs, those are physiological stresses on your immune system. We need adrenaline for energy requirements, for glucose and blood sugar control. We need it for fat burning. So these are all forms of physiological stresses that we typically don't think of. And adrenaline is what helps keep caps on both of those. Now, at any one point in our lives, we're going to have 100 little psychological volcanoes trying to erupt all the time. Kids and family and bills and careers and school and work. But we have to appear calm, cool, and collected when we're outside and interacting with people. It's adrenaline that keeps caps on all those volcanoes. But the same thing happens from the physiological side. So we have colds, flus, bugs or infections. We have food allergies and inflammation associated with that. We have metabolic requirements. We have blood sugar control requirements. We have to detox medications through our liver. So we have 100 little physiological volcanoes erupting all the time over here. Adrenaline in various forms is what helps keep caps on all those volcanoes. And cortisol is one of the major ones that we're going to talk about here. And its primary role for today's video is its anti-inflammatory properties. So think of these hormones as providing a hormonal anti-inflammatory shield, keeping all that stuff at bay, keeping it subclinical during our reproductive and healthy 20s and 30s. The anti-inflammatory properties isn't the responsibility of one hormone, it's the responsibility of them all as a whole. They're continuously running in the background. They're suppressing those inflammatory signals. They're maintaining the protective barrier, our internal skin, the mucous membranes, the internal epithelial structures, to keep a healthy barrier there from infections and other inflammatory agents from causing problems. They're working in conjunction with each other. Now, as estrogen, progesterone, testosterone, and cortisol to some extent fall at perimenopause and periandropause, cortisol is essentially the last one standing. These other hormones are predominantly produced in the gonads, the ovaries, and the testicles. Cortisol is produced from the adrenal glands. So as these reproductive hormones fall, we lose their anti-inflammatory contributions to the overall inflammatory picture. So cortisol has to start to rise to fight all that. It has to compensate for all that inflammation. Even with that compensation, quite often it's not enough to do the job that all four were doing. This is where the inflammatory stuff that may have been here in our 20s and here in our 30s, this is where it starts to erupt. And this is where a lot of these inflammatory symptoms start to surface. But because they surface in our 40s and 50s, it gets blamed on those hormonal deficiencies. They are associated with it, but they are just allowing the inflammation to come forth. They didn't cause those symptoms. This is also why those symptoms tend to get worse as we go from 45 to 55 to 65. That decline tends to happen right through our lives, beyond menopause and andropause. So as we talk about this inflammatory picture sort of surfacing, bursting the bubble as we get older, we can actually trace this back to earlier life as well. The hormonal shield through the years. When we're young, well, before puberty, at 4, 5, 6 years old, our hormones are way down here, and this is where people tend to have some inflammatory issues. Head, ears, eyes, nose, and throat issues, tonsil problems, ear infections, sore throats, asthma, eczema, sort of inflammatory issues in the body. But then as we go through puberty and these hormones skyrocket, they push a lot of those little fires down. So this is where people think they outgrew those conditions. Quite often they don't outgrow them, they grow into them. Their body becomes more able to suppress that inflammation and push it below the surface. The trigger for the inflammation is still there. It's just the inflammation is suppressed enough that we're not aware of it. That's where we think we outgrew it. So as we go through puberty, these hormones rise, they skyrocket. And as they skyrocket, they push all those little inflammatory problems down that the kids may have been having. So asthma may improve, eczema may improve, ear infections may improve, things like that. The trigger for those conditions quite often is still there. It's just we have the ability to fight the inflammation much better after puberty. So those inflammations are sort of running beneath the surface. This is the underlying inflammatory load that we talked about. And that inflammatory load can go on for decades, through our 20s and into our 30s and sometimes into our 40s, before the hormone starts to fall and allows the inflammation to come to the surface. That's sort of shown here. As these hormones start to decline in our mid to late 30s, the inflammation level rises. The protective shield that we had in our 20s, 30s, and 40s starts to lessen, so the inflammation starts to surface. So another way to think of this isn't just a menopausal story. This is actually, there's a lifetime arc of hormone and inflammation that we can see in this diagram. So let's touch on this, but I outgrew it, because that'll happen. That'll come up quite often in visits. They'll say, well, you had eczema as a child, but I outgrew it. Why is it coming back now? Or I had asthma as a child, but I outgrew it. Why am I having sinus and breathing issues now? Again, quite often we don't outgrow those things. We grow into them for a period of time, but then they start to surface. So before puberty, the inflammatory shield is very weak. So we have these inflammatory issues. So symptoms are present. We go through puberty, the steroid hormones skyrocket and pushes the inflammations down. So we have some good years there in the middle. Then at menopause and andropause, these hormones fall. Well, as these fall, these inflammations come back again. Quite often they'll come back in different forms though. So imagine colic in an infant. Quite often that may come back in an adult as either reflux or constipation issues. Spitting up as a baby, that could come back as reflux, GERD, or indigestion in an adult. Asthma as a child could come back as sort of asthma as an adult or other respiratory sensitivities. Eczema in a child can go away, but it can come back and maybe start to surface in other parts of the body as we go through menopause and andropause. The menopause didn't cause these symptoms. It didn't start the fire. It revealed the symptoms. Now we're going to talk about the internal skin, our mucous membranes. Now this slide is actually pulled from an IBS video and a leaky gut video and a couple other videos as well. You may have seen it before. When I say mucous membranes, I'm referring to any part of your body that has a slimy mucus film over it. If you run your tongue on the inside of your cheek, it's that slimy mucus film you feel there. That goes up in your sinuses, it goes down your lungs, it goes from the mouth to the rectum, it lines the urinary tract, it lines the vaginal tract. It's your internal skin. So if you pried your mouth open and pried your bum open, that tube is open to the outside environment. Same thing with your lungs and your sinuses, your urinary tract and the vaginal tract in women as well. So if we didn't have that mucus barrier there, that epithelial barrier, it would be like if we didn't have skin on the outside of our body. So that barrier does a bunch of key jobs. It's a protective barrier. It's like skin out here. It has antibodies in it to help kill bugs and bacteria and viruses we eat, breathe, and drink. It has enzymes in it to help us digest our food. It's a lubricant, so stuff can slide through these tubes nice and easily. We can poop stuff out, pee stuff out, cough stuff out, etc. Now, the important point I want to make here is these mucous membranes are what we call epithelial tissues. And epithelial tissue is a protective tissue that constantly is regenerating, sloughing off and regenerating. Because as this tissue gets damaged, we have to have the ability to replace it and repair it. So as we get older, as we go through perimenopause or periandropause, and we start to see breakdown effects on our skin, like wrinkles and creases and dry skin and brittle skin and things like that, those exact same changes from a hormonal point of view are happening on the inside. So we can imagine what that's going to do to our breathing abilities. digestive tract function and things like that. Tissue thinning, dryness, increased sensitivity. So what's happening on the outside of our body as we get older? It's happening in this internal skin as well, and that's really important to understand. So the hormone impacts on epithelial tissue. Estrogen, it helps maintain cell turnover, moisture, barrier thickness on the inside and outside. So it's not just estrogen impacts on the skin out here, it's estrogen impacts on the vaginal tract as women go through menopause, the digestive tract, the urinary tract, the lungs, all these mucous membrane-based tissues. Progesterone has really significant anti-inflammatory properties and immune modulating properties on this mucous membrane. Testosterone is very similar to estrogen in terms of its ability to sort of maintain and repair this epithelial tissue. So the conventional menopausal paradigm sort of blames the hormonal decline at menopause on vaginal tissue, vaginal thinning and things like that with women. Those same hormonal impacts on the vaginal tissue are happening elsewhere as well. And that's critical to know because it's not just vaginal tissue, it's digestive tract, it's lung, and all these other mucous membrane-based tissues in the body as well. What's going to happen though is the symptoms associated with that tissue thinning and tissue breakdown are going to be substantially different than vaginal dryness in a woman. We're going to talk about andropause in a little bit, but one thing I often mention here when I'm seeing men, everyone has heard of and thinks of vaginal dryness in a woman as a common perimenopausal symptom or a menopausal symptom. Well, men have this too, we just don't have vaginas. So we have the same impacts from a mucous membrane point of view systemically as women do. So it's really just that one particular anatomical part in women where we differ from women with respect to epithelial tissue health as we get older. So as these epithelial tissues become weaker, break down, the connections weaken, dryness happens, the barrier becomes less functional, how that's going to present in the sinuses could be sinus congestion, sinus reactivity, repeat sinus infections if it goes on too long. In the lungs and bronchi, it's an increased reactive airway. Sometimes that can be a resurfacing of asthma. It can also just be more reactions to seasonal allergies or particulate that gets into the lungs. The digestive tract, altered changes there, reflux, indigestion, gas and bloating, diarrhea issues, constipation issues. The urinary tract, increased frequency, urgency, sometimes more recurrent bladder infections and UTIs. And the reproductive tract, this is where the conventional paradigm symptom picture sort of focuses. As you go through menopause, estrogen, progesterone fall, that's where those symptoms lie. But you can now see those impacts that are happening in the reproductive tissue in a woman can also impact all these other parts. So if you have menopausal symptoms with the sinuses or lungs or muscles and joints and things like that, this can sort of show you this, the menopausal hormonal symptom picture can be much broader than what the current conventional paradigm suggests. Now, all these conditions are going to be sort of dealt with different specialists. The reproductive tract in women will have a gynecologist look after those. In some cases, bad skin conditions will be looked after by a dermatologist. The digestive tract issues may be by a gastroenterologist. The GP is going to look after a lot of these. They're kind of considered different conditions, different symptoms. They're managed as separate conditions. But quite often, they're just different manifestations of the same hormonal decline and impacts on that epithelial tissue. We have to give some emphasis here to the digestive tract function as well. We talked about this epithelial mucous membrane issue in the IBS video and a couple of the other videos on the channel here. But it's this digestive tract weakening, this mucosal effects of hormone decline in the GI tract that can really start to magnify and amplify all these other symptoms. And that's what we're going to talk about next. So some of you who've watched the leaky gut video or the IBS video, you're going to recognize this little diagram. This would represent a very rudimentary cartoon-like sketch of an epithelial tissue. This would represent the digestive tract lining. We have cells called enterocytes that are stacked together tightly by what are called tight junctions. They prevent things from getting down in between them. They have little villi to coat and paint and brush the food that we eat with digestive enzymes so it can be chopped up and absorbed into the bloodstream. These cells, again, are held together by these tight junctions. They're basically little Velcro or protein-like Velcro connections between the cells because they have to be held together. We can't have gaps and spaces in between them. We have enterocytes that produce mucus and produce enzymes in the lining of the GI tract. So then we have a mucus surface here indicated by this blue haze that we see. So this would represent a healthy epithelial tissue in the digestive tract. Now the tight junctions, what its main job is it's an immune system interface. It is what actually controls what gets into the body, into the bloodstream, and gets exposed to the immune system there. If we didn't have skin on the outside of our body, if we put bugs or infections or dirt there, there's a really good chance we're going to have an immunological reaction to it that shouldn't happen. Well, this is its function in the digestive tract. It's an immune interface. It controls what's allowed to get into our body and what's not allowed to get into our body. When it's healthy, it's tightly sealed and it's very highly selective. Now we're going to talk about the gut as an inflammation amplifier. As estrogen, progesterone, testosterone, cortisol, as they fall at menopause and andropause, we get weakened tissue collagen integrity, we get a decreased mucus production, we have decreased cell turnover and repair, decreased anti-inflammatory effects of these hormones on that tissue directly. This can lead to basically what people refer to as leaky gut or increased intestinal permeability would be the medical terminology for that. In the image here, you can see it's almost like those little connections have broken. The cells are kind of unzipping. It's leading to little gaps in those spaces. This is an area where infectious agents can get in, so we're going to be more prone to some infections. Sometimes abnormal gut flora like Candida and SIBO can go into those little crevices and hide. This is also where large peptides or proteins can actually get into the bloodstream. The immune system can react to them, and that can create a separate inflammatory process, which is what most of this channel is all about. So again, this would be the leaky gut picture. And estrogen, progesterone, testosterone decline, those impacts that we see on the outside, they're a major contributing factor to this epithelial breakdown on the inside of our body as well. Now what happens as we age? This is where we're going to start to implement the dietary component of this. As we get older, quite often our diets don't change. They become more rigid and more repetitive. We like what we like as we get older. With the hormone depletion, we get a diminished barrier, just like we talked about on the skin with wrinkles. Well, that can lead to these little cracks opening up, the whole leaky gut or increased intestinal permeability that we talked about. Those components, either the proteins, the infections, they get into the bloodstream, which creates an immune exposure and inflammation, which can then come back and make the barrier worse. If we get an inflammation or an infection in a tissue, the infection is going to actually make the inflammation in that tissue worse. So we get into this little feedback loop right here. That's just the hormonal component. But there are lots of women, lots of men who go through that hormonal change and they don't have these compounding inflammatory issues. So there has to be another component or another differentiating factor between them. This is where food comes in. Hidden underlying inflammatory food reactions. We're going to talk about that shortly. If we have a normal hormonal depletion and breakdown of that tissue, but then on top of that, we compound it with some food issues, that can be the difference where this inflammation starts to spin out of control in people who have these more pronounced menopausal symptom pictures. And if these foods aren't new reactions quite often we've been eating these foods and having these reactions our whole life, but the barrier was able to prevent the magnification. Combined with getting older and the barrier starts to weaken, and then on top of that, the food weakens it even more, that is what can start to push it over the break point in that 40 to 50 year time frame. Then when we talk about these food reactions, there's two specific types that we have to talk about. We're going to get into that next. Now we're going to talk about intolerance, allergy, and sensitivity, these distinct types of food reactions here shortly, but we're going to give you a shorter version of those. What I would encourage you to do would be to go to the description and download this free guide, Food Intolerance, Allergy, or Sensitivity. The difference matters, or the difference is critical. This will get into a much more in-depth explanation of how these different types of food reactions create inflammation, some of them don't create inflammation, and why they are so hard to figure out. So that's the more detailed version. I'd encourage you to all go there and download that guide. In short version though, the intolerances are non-inflammatory food reactions and the allergies and sensitivities are inflammatory. From a menopausal and inflammation video, we're going to talk about the allergy and the sensitivity reactions right here. We've talked extensively about this in other videos, so we'll do it fairly quickly here. Food allergies and food sensitivities, they're both immunological reactions to foods, but they react very, very differently in different time frames and they affect the tissues in different ways. The anaphylactic allergies would be what are called immediate hypersensitivity reactions. They're associated with an antibody called immunoglobulin E, or IgE. Immunoglobulin is a big fancy word that means antibody. These are the antibodies that release histamine, and we've all heard of histamine before. It's a compound that causes redness, swelling, itching, hives. That's why people take antihistamines for seasonal allergy issues. These are called immediate because the symptoms of this type of allergy happen very quickly after you eat the food. Someone eats a peanut, their throat will swell up really quickly. Someone eats a strawberry, they get hives very quickly. Someone eats chocolate, they get a headache or a migraine very quickly. So the cause and effect is there when you eat those foods. Also with those reactions, if the reactions don't kill someone with an anaphylaxis, the symptoms will typically resolve within 6 to 12 hours. They come on very quickly and they go away very quickly. Allergy testing or scratch testing, skin testing, is typically targeting this type of reaction. Now with that type of reaction, quite often we can already figure it out if we have that. And most of us would say, well, if I don't have anaphylaxis in the back of the throat, I don't have those types of reactions. But that's not completely accurate. These reactions don't just affect us in the back of the throat. They are highly correlated with a lot of the menopausal symptom pictures, and we're going to talk about that shortly. Food sensitivities, these are delayed hypersensitivity reactions. These antibodies are called IgA and IgG. These are the same antibodies produced to vaccines. They're also the same antibodies associated with a lot of autoimmune conditions. The inflammation with these antibodies isn't triggered by histamine typically. It's associated with those other inflammatory cytokines that we talked about, tumor necrosis factor and interleukins and things like that. The standard allergy testing, the skin testing, doesn't identify these immune reactions. So if you've had a food allergy test and it came back negative, it doesn't necessarily mean you don't have food allergies. You just don't have the immediate type. That doesn't mean you don't have the delayed type. And this is a really critical distinction between the two. So to talk about how these work, we're going to talk about vaccines for a minute. Now we're going to simplify this concept quite drastically. With a vaccine, you get injected with a viral or bacterial protein, an antigenic protein. You get injected with a tiny little dose, about the size of the tip of the pen right there. 0.5 ml is a good standard vaccine dose. Your immune system, your white blood cells, dendritic cells, macrophages, what are called antigen-presenting cells. It's a very complex interaction there. We're going to sort of leave that to another video. Essentially what happens is, combined with a B cell, they set up a photocopy shop and they start printing off antibodies, these immunoglobulins, antibodies and cytokines. These are what go out into the tissues, target tissues, and cause inflammation. Some key points I want to talk about here. This tiny little dose of vaccine can produce a millionfold antibody response to it. And those antibodies to the vaccine can stay in there for a year to 10 years for a tetanus shot, for example. So a tiny little dose of massive immune response lasts for a long, long time. Another thing with a vaccine, when you get it today, it's going to take 2 to 4 weeks for the antibodies to get produced. So when you go on a trip somewhere and you have to have a shot before you go, you have to have the shot 2 to 4 weeks before you travel. Those antibodies need time to get produced. So why are we talking about vaccines with food reactions? Well, the same way you can have that delayed, magnified, long-lasting reaction to a vaccine, we can have that to a food. So imagine we eat a food right here and we have a histamine reaction to it, the quick type. The antibody is going to rise really, really quickly like this. And then it's going to fall very, very quickly like this. So again, quite often we can recognize those conditions. The delayed antibody response, the IgG response specifically, we can eat a food right here. The antibody can take up to 2 to 4 weeks to reach its peak. And then those antibodies will degrade and break down slowly over weeks to months, sometimes years, like we talked about in the vaccine antibody. Why this matters is if we eat a food here, those antibodies could take up to a week to 2 weeks or longer before they interact with the tissue and cause a symptom. So we can eat a food right here. The symptom may happen here, here, or here. Now, if you eat a food today and it causes joint pain next week, you're not going to figure those two things out. If you eat a food today and it causes a headache next week, you won't figure that out. If you eat a food today and you get a skin rash next week, you're not going to figure that out. So if we eat a food today and it bothers us next week and we don't figure that out, what are you going to do tomorrow? You're going to eat that food again. So what happens every time you eat that food over and over again, the antibodies don't rise from zero, they start to compound. They start to build up on top of each other like this. This will ultimately lead to a chronic, compounding, overlapping inflammatory response that you'll never correlate back to a food in your diet. This is the critical point. This is why these food reactions are often hard to figure out. If you eat a food tonight at supper time and you don't feel well, we're not sure if you don't feel well because of the food you ate at supper, the food you ate yesterday, the food you ate 3 days ago, or the food you ate last week. So this is where food journaling is very difficult to sort any of this stuff out. These histamine reactions, quite often we have them and we don't notice them because the histamine reactions can be masked and covered up by these delayed reactions. We could eat a histamine reactive food right here and it'll go up and come down like that. And it'll cause this symptom right here. Well, you could eat a food last week that could cause the exact same symptom at that same time frame. So these delayed, magnified, compounding antibody responses that cause inflammation can mask and cover up a lot of these histamine issues. We can see now where this can get really complex and difficult to figure out. Now, a classic example of this could be celiac disease. Someone eats gluten, represented by this little red squiggly line. The T and B cells interact with it. They produce antibodies to attack anything with that shape in the body, specifically IgA antibodies. Well, these antibodies will go to the bowel, and people with celiac disease, they can have a protein in the bowel, in the mucous lining of the bowel, that can mimic the gluten. So the antibody produced to attack the gluten food can go and attack a tissue protein that looks like it. And this is called molecular mimicry. So this is a medically accepted and documented and well-researched version of this delayed food sensitivity or this food reaction triggering inflammation in the body. Now, what this video is about, what a lot of my other videos are about, is this concept that if we can be allergic to gluten, produce an antibody to it, and have the antibody cross-react with the tissue protein in the body that looks like it and cause inflammation, why couldn't a different person with different genes and DNA be allergic to a different food and the antibody cross-react with a different tissue? That's logical, and that actually makes quite a bit of sense. That protein, if that was in the skin, if we eat gluten, we produce an antibody to it. Well, if we have a protein in our skin instead of our bowel that looks like gluten, that could actually go and cause a skin rash. If it's in a joint, if the synovial tissue covering a joint, that could actually cause an inflammatory arthritis. In the nerve, it can cause neuropathy and other nerve issues. In an organ or a gland in the liver, it could affect cholesterol or autoimmune hepatitis or non-alcoholic fatty liver disease. In the glands, it can affect the thyroid gland. There's a lot of research supporting Hashimoto's thyroiditis with these types of food reactions. In the pancreas, there's actually research correlating type 1 diabetes with antibodies to casein, which is a milk protein. So this molecular mimicry concept is established with certain foods and certain conditions. It's just where it's a food condition, the research is lagging extremely with respect to considering this food reaction affecting other tissues in the body. I'd suggest you subscribe because we're going to have a video just specifically on autoimmune disease, molecular mimicry, and diet coming up shortly. Now let's talk about histamine a little bit, the major menopausal menace. Now again, most people with histamine issues, they think of seasonal allergy issues, a dust cloud, a pollen cloud. Those are very real histamine reactive components for a lot of people. But quite often, histamine reactions to foods can play a major role with respect to menopausal symptoms. Histamine is a major signaling hormone in the body for inflammation. It's stored in mast cells, these little balloons filled with histamine, and this mast cell is basically in every tissue in your body, and it's in high concentrations in the epithelial tissue as well. It's in the skin, the gut, the urinary tract, the bladder, the brain, the lungs. It's everywhere in the body. An allergen can come in if, through a very complex interaction with a mast cell, it can break the mast cell open, the balloon bursts, and the histamine gets released in that tissue, and histamine causes all these inflammatory symptoms. The histamine release in different tissues will lead to different symptoms. So histamine issues in people in the skin, imagine someone who eats a strawberry and they get hives. That's a flushing, itching skin. Histamine can cause something as simple as a flush or a hot flash. I've treated hot flashes in 14-year-old little boys before because they were having histamine reactions to foods that they were eating. When someone drinks a glass of red wine and they get flushed in response, quite often it's a histamine response to the wine because red wine is extremely high in histamine. Histamine in the gut can cause something as simple as reflux and gastritis. Gastritis, a common symptom of that is nausea. When people have nausea, they take a common medication called diphenhydramine or Gravol or Dramamine. That medication is an antihistamine. It will only help with the symptom if the symptom is caused by histamine. Some of the medications for reflux are actually antihistamine medications. So histamine can cause something as simple as heartburn or reflux. It can cause nausea, it can cause bloating, constipation in the bowels. There's a proven mechanism for that with opioid-induced constipation. The histamine release in the bowel causes the bowel to puff up and swell just like your sinuses would. The histamine causes the mucus to get sticky. If we inflame the bowel, we shrink the diameter of the bowel, we make the mucus sticky, it's going to be very difficult to have a bowel movement through that shrunken tube. Histamine issues in the intestine can actually lead to urgent diarrhea episodes. Histamine in the airways can lead to reactive airways. Sometimes people with breathing issues can see relief when they take an antihistamine. Histamine can cause bladder urgency and frequency and irritation. Histamine in the brain, headaches, migraines, and brain fog and anxiety. These are the inflammatory signaling mechanisms, of which histamine is one, is well researched with respect to some of these things. Histamine has a major impact on our sleep with wakefulness when we're tired. It's called wired and tired is the concept. We're going to talk about that next. So ask yourself, does your menopausal symptom picture include any of these things? If it does, then we have to consider histamine as being part of your menopausal symptom picture. From a hormonal point of view, estrogen, progesterone, and testosterone are tied to histamine as well. We talked about this before. A decrease in estrogen decreases that diamine oxidase or that histamine clearing enzyme. That leads to decreased histamine clearance. That can lead to a histamine rise or an inflammatory rise associated with histamine. A drop in progesterone increases mast cell destabilization, so that can lead to mast cells breaking open more easily, which will release more histamine into the tissue. The hormonal effects of estrogen, progesterone, and testosterone can increase the gut permeability. It increases exposure of the gut and the tissues in the gut. So histamine can be quite a significant contributor to a lot of the menopausal symptom pictures, which are inflammatory symptoms in many people. Now, an important distinction here. I'm not referring to foods that are high in histamine. Most foods aren't high in histamine outside of the red wine that we talked about before. Histamine reactions can be released to foods that have no histamine in them. This is where the internet takes us a little bit too far. There's a never-ending list of low histamine diets out there. So I've been in practice for a long time, and I've seen basically the most benign foods you could ever imagine trigger histamine releases in people. And these could be foods that could be top of the list from a low histamine or a low histamine diet food list point of view. So just if you've tried a low histamine diet and you didn't see any impacts with it, it doesn't mean histamine is not part of the picture. It just means maybe your histamine reactive foods didn't comply with the foods that that list suggested were okay for you. What is inflammatory for each of us is unique to each of us and each of us alone. It's determined by our genes and DNA. We're going to talk about that shortly. So histamine with the wired and tired. This is where people were exhausted, but we can't get to sleep. Histamine is a major wakefulness signal. It's your alert hormone. It's your ready for a crisis hormone. If you're in a situation you're trying to sleep, but you know something can happen, histamine can be that hormone that just keeps you on alert. A high histamine load caused by something like food can explain why we can be exhausted and not turn off. This can actually be a histamine issue and not a hormone issue. But if you're wired and tired and laying in bed and you're a 50-year-old woman, it's very quick and easy to just pass it off as being menopause. But again, if that was the case, then every woman at 50 with that hormone decline would have the same sleep issues, and they don't. Histamine can be a differentiating factor for those women. So another anti-inflammatory test that we can consider here. Antihistamines block histamine. That's their one main mechanism of action. So if someone takes an antihistamine like Benadryl or diphenhydramine, and if it helps them sleep, quite often the sleep issue was caused by histamine, and the antihistamine dropped that histamine and allowed them to sleep. So if an antihistamine helps, histamine was likely part of the problem. So now a quick mention about HRT or hormone replacement therapy. And it kind of fits into this anti-inflammatory test that we were talking about before. The HRT, the intention there is to restore the hormones from a reproductive and anti-inflammatory point of view, although those hormones aren't intended to reproduce periods and things like that. If we think of these hormones, estrogen and progesterone, which are typically part of the HRT protocol, if we think of them as anti-inflammatory hormones, which we now know they are, a lot of the symptom relief that we get from HRT may be because of the anti-inflammatory properties of that HRT, as opposed to the reproductive hormone replacement. The HRT can suppress those inflammatory signals, and any symptoms associated with those would start to improve. So we talked about an NSAID helping with muscle and joint pain. We talked about an antihistamine helping with histamine issues. Well, HRT, hormone replacement therapy, can cover a lot of those anti-inflammatory jobs as well. Now, a key point here, a lot of women on HRT can still have symptoms going on. This would be an indication that the inflammatory load, the estrogen progesterone replacement, isn't enough to suppress that overall load. So this is where that other underlying cause, this sort of what I call upstream inflammatory trigger, is probably a still significant part of that woman's symptom picture. So let's revisit that anti-inflammatory test concept. If NSAIDs help, ibuprofen, naproxen, etc., if they help with a menopausal symptom, that symptom is likely an inflammatory symptom. Steroid creams for menopausal symptoms, dry skin or rashes and things like that, if they help, steroids are anti-inflammatory. They're not hormonal. That was likely an inflammatory symptom. Antihistamines, we just finished talking about that. If an antihistamine helps with a symptom, it's likely a histamine issue, which is an anti-inflammatory medication, not a hormonal medication. And HRT will help with the menopausal symptoms, possibly because of its anti-inflammatory properties, not because of its reproductive hormone replacement. So with this concept, we can sort of think of all those things as suppressing inflammation. And quite often, a lot of people will manage long-term with that approach. The question I'm going to raise here, and the question that I raise in all of my videos, is what is causing the inflammation? Inflammation always has a trigger. The immune system doesn't just arbitrarily decide to attack things randomly. It works by what we call a lock and key mechanism. So we have to figure that trigger out. That's what we're going to talk about next. So inflammatory food reactions are immunological reactions. It's a sort of a white blood cell or a mast cell interacting with something that's not supposed to be there, or what your body perceives is not supposed to be in your body. The white blood cells have receptors on them. They're like little arms with gloves on the end or feelers on the end. These receptors bounce into things in your body and they touch things, and they determine what's allowed or not in your body by how they feel. So this is the lock when I refer to lock and key. Well, the allergen or the antigen, the thing that goes into the lock, is what turns the lock and turns on the inflammatory cascade. So these white blood cell receptors actually have to bind to something to trigger all this inflammation. So quite often people say, well, it's stress. Well, can a thought in your head bind to a receptor in a white blood cell? Stress can fan a fire, feed a fire, make a fire worse, but stress typically doesn't trigger the inflammation. There has to be a structural, mechanical key going into that lock to turn on the inflammation. Your DNA determines the shape and structure of this little lock. So the receptors, what your immune system will react to allergically, is determined by your genes and DNA. It's not determined by a diet program on the internet or TikTok or YouTube. It's not even determined by a lot of the generic diet programs out there, the paleo diet, the AIP diet, things like that. So when people try these diets and they don't see great responses with it, quite often they'll conclude that diet's not part of the symptom picture. But when in fact it usually is. It's just those diets didn't happen to fit their immune system profile determined by their genes and their DNA. Your ideal anti-inflammatory diet is unique to you and you alone. We have a video on YouTube. It's one of the first videos that was up there called The Trouble with All Anti-Inflammatory Diets. It explains this concept in great detail, and it shows you examples with testing results and things like this, where people were eating healthy foods, what they perceived as being healthy foods, that were actually causing their inflammation. And it shows the opposite. It shows examples where people were eating foods that they thought may have been unhealthy for them, and they turned out to be okay. I'm not proposing eat unhealthy foods. I'm saying we need to figure out what foods are actually healthy and unhealthy for you through this genes and DNA. So I'd encourage you to watch that video if you get a chance. The link will be in the description. So these generic diet plans, they don't take into account this unique genetic structural aspect to our inflammatory food reactions, the lock on the white blood cells. This is one of the main reasons why these generic diet plans don't work. Generic healthy isn't always healthy. The next issue, these diets often reduce, but they don't remove the inflammatory triggers. They'll say restrict, cut these foods back in your diet, everything in moderation. Well, from an allergy point of view, that would be like saying to a kid with a peanut allergy, don't eat a whole lot of peanuts, but 1 or 2 peanuts will be okay. With allergy restrictions or sensitivity restrictions in the diet, it really needs to be complete to see full responses. That's another major issue. Quite often the diets weren't done long enough. People say, well, okay, I love this food, so I'll try giving it up for 3 or 4 days. Well, think of that delayed immune reaction we talked about. If you eat a food a day that causes an immune reaction that can peak 2 weeks later, if you give that food up for a week or even 2 weeks and you don't see improvements, it doesn't mean that food wasn't causing a problem. It means you didn't do the diet long enough for the antibodies to start to fall to where the symptoms would start to show improvements. So these are 3 of the main reasons why these generic programs sometimes fail to produce results. People say to me all the time, well, I did an elimination diet and it didn't work. And what I say to them is, you did an elimination diet. You didn't do your elimination diet. That's a really important distinction to make. The elimination diet premise was correct. It just, the method wasn't, and the diet wasn't correct for you. Now, I've mentioned andropause several times through this video, and most of the people watching this video are likely going to be women because the title is menopause. Men go through the exact same change that you do. We just don't have vaginas and periods to show for it. I joke with patients sometimes, men lose their hair and their erections and women lose their periods. Women get us back later in life for all the trouble they have during their menstrual life. So testosterone is a significant anti-inflammatory in both men and women. Some women don't realize it's a major part of their hormonal picture as well. It's about a 1 to 2% decline from our mid-30s onwards. So the andropause or menopause change that men go through, it's not as dramatic. There's not a defined timeline to it. There's not an acute change in our physiology like when a period is there and a period stops. We go through it in a more slow, gradual point of view, but it tends to speed up when we hit our late 30s and early 40s as well. The symptoms are very similar: joint pains, fatigue, sleep issues, brain fog and fatigue, digestive changes, and things like this. Every symptom that I just talked about from a female point of view are in this list for men as well. It's just different hormones and different timelines and different presentations of it in terms of speed of onset of the symptoms. So why this is important for women, there's a few reasons. Some of you may have men in your life that are being unbearable and being stubborn. I can say that because I am a man. Well, if you can convince them to watch this video on menopausal hormone changes, they may see the benefit. They may see some of these aspects in their own life. And maybe if we can make them better, your life might get better. The other thing that this andropause or testosterone issue does is it actually validates the whole concept I've talked about in this video. The conventional menopausal model, estrogen and progesterone decline at menopause. This leads to all these symptoms that we've talked about. Well, men experience these symptoms as well. So what this says is that symptom mechanism is not sex dependent. So there's got to be another aspect to it. If we're talking about menopause with estrogen and progesterone, that's not part of the man's profile. So if men go through these exact same symptoms, just in slightly different form, different speed of onset and so forth, the whole concept of inflammation associated with hormone decline in both men and women is actually validated. The anti-inflammatory or hormonal shield that keeps all that inflammation at bay weakens in both men and women. So this inflammation, this symptom picture we're talking about, erupts in both men and women. That actually validates the whole inflammatory process for women and for men. Now, the major point I want to make here is that inflammation often has a dietary trigger associated with it. And that's what we need to figure out. The reason for this is we can't make a 45-year-old patient 25 again. And we don't have another puberty to look forward to as we get older. So as we get older and these hormones continue to fall without another hormone spike, the inflammatory issues can actually get worse and worse and worse. And eventually some of the symptomatic cover-up stuff that we use to manage the inflammation becomes less and less effective. So finding that immune trigger becomes more important as we get older. So we're going to circle back to that first slide at the start of the video. We have woman A who has very little inflammatory load, and this is where she may have had very little impact through her menopausal years. We had woman C here who had a major inflammatory load, and her symptoms started much earlier and went on into her 60s. Her inflammatory load, that inflammation, always has a trigger. Quite often, the inflammation trigger is dietary, and the diet is something we can adjust. If it's a dietary trigger, we can find it and we can eliminate it. So quite often, a lot of these menopausal symptoms that a 60-year-old woman says, I just have to live with, quite often we don't have to live with them. That's the key take-home message for this. So if we have these food issues, how do we figure it out? Well, we need a very systematic approach to it. The generic approach, the books online, the food list, the good foods and the bad foods, the supplements that suppress the inflammation. There's a good chance you may have tried some of those things, you may have tried some of the diets and you didn't see great impacts with it. It's because they weren't specific to your unique physiology and immune system. That's what the system has to focus on. So it's a technically different method. We have to identify the delayed reactions, these ones that compound and build up over time. Then we have to identify if there's any IgE histamine reactions. Again, you can have both and they can mask each other. The diet program has to account for the differences in timing, with histamine issues happening very quickly, delayed reactions happening anywhere from a few hours to several days after you eat the food. We have to account for the unique and individualized nature of how our immune system interacts with foods. We can have 10 women or 10 men with the exact same menopausal or andropausal symptom picture. They can have 10 completely different sets of foods triggering their problem. But the way the internet works, YouTube and these generic approaches work, we try to assign one diet or one inflammatory trigger to everyone with the same problem. And people just don't work that way. Those locks on the receptors in the white blood cells, they don't care what a diet program on the internet says or what a health guru says. They only care what your genes and DNA said in terms of constructing them. So it's very unique and individual. That's what it has to focus on. And finally, that we have to do, when we eliminate these foods and we feel better, we don't just put all the foods back in again. We have to put them back in a really structured manner, one at a time, with a proper time frame in between each food so we can account for the delayed and immediate reactions. I don't expect you'll be able to put a program together just based off of that information. The point with this slide is to show you that all of these little details in terms of the programs, they make or break whether we get this figured out. This is the work I do with patients in clinic. Now, quite often I don't have the ability to work with them. I have put together a course which talks people through that program. There's going to be a link in the description below. So I would start with that download that I mentioned earlier, the food allergy intolerance or sensitivity download or guide. It's actually a summary of the first module of the course. So it's going to give you a good indication of the type of information we're talking about, but also the importance of those 3 different types of food reactions. That's where I would start. Back to the main question that no one asked about menopause. Why do some women suffer so badly and other women don't suffer at all? Well, the inflammation was always there. Quite often the hormones at menopause just stop suppressing the inflammation. When the hormones declined, the shield weakened and the inflammation came to the surface. But because the inflammation came to the surface at that time in your life, it gets blamed on the conventional paradigm that we talked about. So there's a link in the guide. You can scan that QR code for that free download. I'd encourage you to do that. All of the information we talked about in this video, it's actually in more detailed form with research to back up the claims that I've made in a book called Menopause Revealed, The Inflammation Your Hormones Are Hiding. There's a link to that in the description below as well, and that link is also on the website immunity.com. So I hope you take away that your menopausal symptoms aren't a sentence, they're just a susceptibility. There's quite often a trigger for those symptoms, and the trigger is something we can identify. Thanks, and we'll see you in the next video.